All right, it is 12 o'clock, so we're going to go ahead and get started. Welcome everyone to Medical Grand Rounds. It has been really great to see you all this year, and I say it in that way because this is the final Grand Rounds of the season. So I hope the educational process content has been great. And the process has been fun. We're going to take a little bit of a pause for the summer and then look for an announcement from either Jennifer or myself with our upcoming Grand Round schedule due to start in the beginning of August. As a reminder, there's CME and MOC credit for all Grand Rounds, and then questions will probably come live from our audience because it is very packed today, but thanks to the Chief Medical Residents who will watch the Q&A feature. Before I introduce our speaker, Dr. Clyde Yancy, I want to turn things over to Dr. Peter Buttrick, Senior Associate Dean for Research Affairs in the School of Medicine, recent Division Head of Cardiology, to talk about the Blount Lectureship.
Thank you all for coming. It's an annual pleasure for me to introduce this lectureship. The lectureship is named in honor of Gil Blount, whose picture is up there. Gil was the first Division Head of Cardiology at the University of Colorado, and remarkably served in that role for 30 years. Just reflect on that for a moment. His contributions to cardiology were immeasurable. He received almost every honor that could be bestowed upon a person by our national organizations. If you were to ask him what he was most proud of, and I have to say I actually had the opportunity to do that because he and I overlapped by a few years, he said he was most proud of his trainees. And I think in total, he trained more than 1,000 cardiologists who populate the state. And one of the great pleasures for me in introducing this lecture is that I get to acknowledge some of his trainees who are in the room, who contributed to the support of this lectureship. So I see faces, you can stand or not, but I want to thank you for your continued support of this lectureship of the division and your continued recognition of Dr. Blount's contributions. Looking, there's one here, there's a couple back there. The community is thinning slightly, but we really appreciate the fact that that you all come. Dr. Blount, just to put his contributions in some context, he trained in the East Coast. Richard Bing and Helen Taussig, two names in cardiology that hopefully some of you have heard of, contributed to his training. And when he was recruited out here in about 1950, he started our cath lab. He participated in the creation of the High Altitude Research Center and really, I think, changed the face of cardiology in the West. So I just want to put a little bit of historical context in place. And we are really fortunate every year to be able to honor him with really distinguished speakers. And I'll let Jeff introduce our today's distinguished speaker.
Thanks, Peter. I appreciate it. And I think honor, is, let you do that. I say honor is the correct word for given who our speaker is today, Dr. Clyde Yancy. You embody everything that this lectureship is about, and thank you very much for being here today. Dr. Yancy is the Vice Dean for Diversity and Inclusion and a Professor of Medicine and the Chief of Cardiology at Northwestern University Feinberg School of Medicine in Chicago. He also serves as the Associate Director of the Blount Cardiovascular Institute at Northwestern University Memorial Hospital. He holds the Magerstadt Endowed Professor Chair as a professor in the Department of the Medical School Social Sciences. He did his undergraduate work at Southern University, where he graduated with honors. He was a medical student at Tulane University, graduating AOA. He was an intern and resident at UT Southwestern and also completed his fellowship in cardiovascular diseases at UT Southwestern, where he then went on to complete a fellowship in heart failure and transplantation. He has advanced training with a master's, with a MSc in healthcare management from UT Southwestern, as well as a certificate in advanced leadership for physicians from the Southern Methodist University Cox School of Business. I did learn by reading his CV that I could give a 1-hour Grand Rounds on Dr. Yancy, so I'm going to cut this a little bit short. But I do want to note that upon finishing his training, he then spent 17 years on the faculty of UT Southwestern, where he held the Carl Westcott Distinguished Chair in Medical Research. He was the Associate Dean for Clinical Affairs and served as the Medical Director of the Heart Failure and Transplant Program. And then in 2006, was named Director of the Baylor Heart and Vascular Institute in Dallas. His research interests are in heart failure, clinical guideline generation, outcome sciences, personalized medicine, and healthcare disparities. He is extensively published with over 700 peer-reviewed publications, placing him in the top 1% of cited authors worldwide. Dr. Yancy currently serves as the deputy editor of JAMA Cardiology and the senior section editor for JACC Heart Failure. He's an elected member of the National Academy of Medicine and the American Association of Physicians. In 2018, he was appointed to the Minority Health Affairs Subcommittee for the Department of Health and Human Services for this country. In 2022, he received the Heart of Gold Award at the AHA Heart Ball in Chicago, as well as the Heart Failure Society Distinguished Leadership Award for his commitment to education and mentorship. Dr. Yancy, I know that doesn't cover it all, but thank you for being here.
Good afternoon. Is this lavalier working well? Well, good afternoon. I'm trying to understand why you didn't respond. I said good afternoon. Now the lavalier is working well. This is terrific. Jeff, thank you for your kind introduction. And Peter, we've got a great history together, so I can't thank you enough for the invitation. I really want to even elevate my gratitude because for the opportunity to be here and provide this kind of eponymous lecture and respect the legacy of Dr. Blount, it really is a humble privilege for me to be in that space. I know the names of some of those who've governed this before, and so that's another reason why I'm so grateful to you for this invitation. So thank you, and thank you for being here. Now, I thought I would start with this first graphic because if there's nothing else you can take away today, you get one more opportunity to celebrate this first ever experience for your Denver Nuggets. But you know, there's a lesson in leadership here, which I think is really valuable. It shows what happens when you put together your team, emphasizing team, develop your plan and stick with it. So many times in leadership, particularly in healthcare leadership, we keep iterating the team and changing the plan, recalibrating, reorging, and we never get the success we see. But by staying true, I think your Denver Nuggets were a great example of the way we should go forward. I'm obliged to share this scan code with you, so I'll pause for a few moments. I see some are taking the requisite pictures so you can receive credit for attending today's discussion. I too want to pay homage to the namesake for this lecture. I say that with a very serious intention. As much as medicine has become digital, virtual, based on metrics, ultimately, what makes us physicians is one physician touching, training, and teaching another physician. Mike Bristow is seated to my left. When I was a fellow at UT Southwestern, he was a visiting professor. We were talking about managing heart transplant patients, and he looked at me and he said, "You have to become really good looking at neck veins." And I took that to heart. But it was one physician treating and teaching and touching another physician and letting us know how best to go forward. So for the 1,000 or so physicians that Dr. Blount touched, this really is the legacy of medicine, where one doctor teaches another. And so it's another reason why I'm very pleased to be in this space. Now, as I did my own review, I saw there were a number of things that were, I think, very important, including service to our country and the Army Medical Corps. But I too have a connection with Helen Taussig. I spent a fair amount of time studying pediatric cardiology, and one of Helen Taussig's primary mentees was my direct mentor who taught me how to examine children and interpret pediatric ECGs. So seeing Helen Taussig here really generated a bit of a moment for me. As well, I've been involved in trying to elevate the contribution of Vivian Thomas to the famous Blount-Taussig shunt procedure. So again, I was pleased to see this. And now as we look at the rest of the attributes, what I'm really struck by was the commitment to training others. I'm glad the number is not 200, but 1,000. But everything that I've seen is about training others. Now, in a very gentle way, I'll tell you that I've listened to discussions with some over the last 2 days and others that I know. And so what can you tell me about Dr. Blount? What's not on the screen? What's not in the biographies? Apparently, he was a fairly large man, had some stature. He was maybe domineering. Back in the day, we might have called that slightly intimidating. It's the way we used to do things. And apparently, he could be very direct, very forceful. And I think is that correct? Absolutely. And that's the way we learn medicine. So I think we should never get too far removed from acknowledging the legacy of academic medicine. So let's begin. I think it's very important that in the curriculum of Grand Rounds discussions, we incorporate aspects of the contemporary approach to cardiovascular health and cardiovascular medicine. That dimension that merits inclusion today, in addition to everything else you've seen, and I realized that earlier in this Grand Round series, you had a discussion about health equity attained through process improvement, but it really is understanding where we are, what does this mean, how important is health equity, and what are the necessary steps to take to get there. I start with this very plain spoken quotation from 1905. I don't need to recite it, but I think you can understand the intention here. And that is a segue to the experience that we all remember just 3 years ago. Think about that. Just 3 years ago, you know that at least in the first wave of the pandemic, the disproportionality of the burden of disease was expressed as a function of race, ethnicity, and particularly Native American heritage. And so it really exposed not just disparities, but the pre-existent, if you will, built into the environment evidence of inequities. So if there is a lesson to be learned, if we are to take that not as a historical footnote, but as a platform, as a lever to think about how we go forward, then I'm suggesting to you that equity is a direction that we should pursue. This is the obligatory outline, but it really is to help us all get on the same page, not just with nomenclature, but as we are trained to do as scientists, to think about the science behind equity and how can we evolve a mutual understanding. This graphic is both simple and profound because it demonstrates what happens when everyone receives the exact same good or service. That's equality. And when each person receives that which is most appropriate for them. On the topmost panel, you have 25% success with someone receiving a good or service that actually is effective. On the bottom panel, it's 100% effective. So it is a simple graphic, but it is profound because it conveys the message that sometimes providing the same thing to each person doesn't yield the same outcome. So if that graphic sets the stage, what is an operational definition? How can we get this vernacular in a place where we can all speak about the same thing? Let's make reference to the Center for Diseases Control and understand a definition put forward that really is a guiding statement now. And I'll only read the beginning and allow you to read the rest of this. But health equity is achieved when every person has the opportunity to attain his or her full health potential. I'll leave it up for a few more seconds so you can finish the thought process. But this is the ground truth. If we really are going to say that what we've learned from our past experiences over the past 3 years is the necessity to think about health equity, different from health equality, this is the definition that's operationalized. But if we're going to say that's the statement, then what's the aim? What's the trajectory? So let's make reference to the National Academy of Medicine. 2 years ago, in September of 2021, there were a series of statements that basically said, here is the goal, and here is the agenda. And the agenda that was actualized by thinking about the same thing we do in quality improvement. That is, we acquire data, we analyze the data, we reassess our strategic plans, and then we get more data. And it's a continuous cycle of quality improvement. We all know this completely well. But as well, a 6-step plan was suggested by the National Academy. First, embed an equity lens in all that we do. Second, create a dashboard that allows us to see real-time how things are progressing, and make certain that dashboard is in plain view of the leaders of health systems. Second, third, and this is so incredibly important, leadership must be engaged, commitment, resources, and infrastructure. Fourth, ensure diverse leadership at all levels, and I'll explain why that's important as we go on. Fifth, empower and equip quality officers within the healthcare system to take on this work. And most of that means providing effort so the work can be accomplished, and then improving the quality of the data. So you can see that the core principles here of the 6-step agenda identify that it's a necessity, not an option, but a necessity. Get there through a system of continuous quality improvement and incorporate quality data, committed leadership, and team building. Victor Zhao, whom many of us know personally, went on to further articulate this just about a year and a few months ago. There is no equity without quality, and there is no quality without equity. When quality improvements don't intentionally address equity, it may worsen disparities. As quality improvement efforts are implemented, they must be held accountable for reducing disparities. Data are incredibly important. Leadership is the key asset we need to be successful here. Now, to continue to think about how does this actually occur, in medicine, we respect certain levers that are irrefutable. One of those levers is, in fact, the Joint Commission. The Joint Commission is beginning to incorporate an assessment of some measure of health equity as hospitals undergo reaccreditation. The same can be said now for the U.S. News and World Report construct. No matter how imperfect that model is, it is still the template used to compare institutions across the country. And overtly, health equity, not disparities, is incorporated in that as well. So one has to say, well, we've gone a long way in a short period of time, seemingly, because now we're being held accountable. We have the National Academy saying we must do these things. Can we kind of recalibrate and figure out how we really get here? Whenever you have conversations like this about health equity, about how we interact with different cohorts, different groups of people, necessarily, and I want to be very clear, necessarily, there will be statements, there will be thoughts, there will be feelings that we'll all have that are either comfortable, reaffirming, reassuring, or uncomfortable, or disquieting. An effective speaker makes certain that in the audience, somebody is moved to collaborate, to acknowledge, to agree, and somebody else is moved to think, to reconsider, to wonder. And so that's the purpose for having these kinds of conversations, because it's part of the educational process. So with that in mind, think about this very common scenario. And I'm going to use a disease process that I know is studied on this campus as we speak, peripheral vascular disease, peripheral arterial disease. So think about a practitioner and patient at the point of the interview. At that interview, there's the upload of objective data, if you will, imaging studies, Doppler studies, laboratory studies. And there's this critical moment of the interpretive eye. At that time of interpretation, yes, we use our cognition to make the decisions that we're trained to assess and bring forward, but we also have a subjective dimension to that. This is grounded in social theory. This is not theoretical. If that subjective assessment incorporates with some reason that patient's specific influences, then the interventions are favorable. In this case, limb revascularization. But if that subjective interpretation is somehow or another persuaded by conscious or unconscious thinking, referable to stereotyping or worse, that intervention, in this case, may lead to a disproportionate number of amputations. Now, forgetting about PAD and thinking about what we do in cardiovascular medicine, TAVRs, AF ablations, referral for heart transplantation. Whenever groups of people get together to make decisions about patients, and those decisions involve not just the objective assessment, but some subjective upload about your assessment, your sense, your gestalt about a patient, we are at risk of making decisions that may vary quite substantially. Now, you might say that model is interesting if we limit it to those specific disease processes, but in the same National Academy initiative in which I was involved, there was a commissioned survey from Press Ganey to look at things that are in the vernacular in today's hospital systems. Vinit, we talked about this earlier today. We're talking about clinical excellence, caring behaviors, operational efficiency, the global ratings, dashboards, if you will, the sorts of metrics that hospitals deem to be important. Look at the categories, and how many of us don't appreciate what top box scores means now? We may not have learned that in medical school, but now that's important. If you look at all of the groups, Hispanic versus not Hispanic, Asian versus not Asian, Black versus not Black, white versus not white, in each category of care coordination, of caring behaviors, of operational efficiency, only one group seems to have positive experiences consistently. This is contemporary. This is not historic. This is post-2020. So it gives you a sense that there's some things that are evident truths, perhaps baked into our infrastructure or our culture, that are still accessible. I'll give you an example of some recent research that we've published just within the last month. This was in JAMA, working with Harlan Krumholz, the two of us as senior authors. We worked with a team over 6 months out of the Yale Outcome Sciences Group. And we started with this hypothesis. Can we think back 2 decades worth and understand what is the similarity or dissimilarity of mortality as a function of race in this country? The data sets we use, the CDC won the database. When we looked at causes of death adjusted for age and sex, what we discovered was quite remarkable. These two graphics, panel A and B, show us either mortality rates or years of potential life loss. The numbers require some pause. Over a 21-year period, 1.6 million excess deaths in people who were identified in their death certificate as Black. 80 million years of potential life loss. What's the disruption to communities, to families, to economic environments? But here's a part that's even more compelling and makes it relevant. If we look at the causes of death, the top 3 reasons why this disproportionality existed was not gunshots and assault, even though assault is on the list. It was heart disease, it was cancer, and it was infant mortality. So the burdens that we've been addressing globally, trying to understand how do we create an equitable environment, particularly at the threshold of risk factors across our communities, seemingly were responsible for these outsized disproportionate deaths and this excessive amount of years lost. In the same issue, colleagues we know at Tulane School of Public Health, Tom Levis was previously at Hopkins. He and I have worked together before on a number of initiatives, made an effort to say this: what if we take people that are not college educated, assuming a college degree is your ticket to reasonable prosperity, take those that are not college educated, understand their burden of disease, and then quantify this and understand what's that cost. The numbers are striking. Over the index year of 2018, it was over $400 billion, attributable to lesser income from poor employment characteristics, unemployment, or other contributions from within their societies. But what was really fascinating, I've shown the arrows, they did a state-by-state per capita analysis. Here's the key consideration. The groups studied represent 9% of the population, but 26% of the per capita expenditure for dollars lost due to health inequities. And then in each state, they calculated per capita how much those different groups contributed to that excessive expenditure by state. So in Colorado, the biggest cost group was American Indian at well over $10,000 per capita, followed by those self-described as Black. In my state of Illinois, the American Indian and those described as Black are about the same. But it gives you a sense that there is a thought process that helps us monetize the cost we pay for health inequities. So even if we socially disagree with taking an approach to normalize equity, we are paying a price for it nevertheless. I continue to tell audiences that the absence of health in any one of us affects the health of all of us. And as we begin to operationalize that thought process and appreciate these kinds of modeling exercises, we go a different place. Now, you've heard my preamble about this part of my presentation because it's intended. It is intended to make you think. It's intended to make you have a conversation with your significant other this evening. It's intended to make you feel at ease because someone's talking about these. That being the case, let me share with you a very important statement from the Aspen Institute. The Aspen Institute is a think tank. Again, I've had the opportunity to work in a limited way with them. But their definition of structural bias, and I'll just read the first sentence: a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. You can read the rest. Point being is that if we can allow ourselves to get over the emotive response we hear when we talk about structural or systemic limitations, there once again is a vernacular, an operational definition that helps us understand that we can define what this actually happens to be. Now, for this next statement, I am going to be silent, and I'm going to read it with you during this silence. It'll take us all about 15 seconds. This is from C.S. Lewis. I think you can understand the point that we're conveying here. But let's continue this exercise. COVID-19 made us realize a number of different things. One of the earlier publications that I introduced into the JAMA network was assessment of the disproportionate burden of deaths in Chicago in the early phase of COVID-19. In the 1930s, there was an initiative to address the housing shortage in the post-World War I United States. The federal government appropriately acted and said, let's back mortgages. To do that, an entity needed to be created. It was the Federal Homeowners Loan Association. That homeowner loan association was given the responsibility to make an assessment of creditworthiness and to assign those areas with the least amount of creditworthiness a D, and literally on a map to draw a red line around those communities. This is the map. I went to the archives and pulled the map. This is it in Chicago. I have the privilege of living and working here, but I know all of these communities. These were the actual red lines. Those were communities where mortgages were not secured. Now, ordinarily, you would think that people would migrate from the lesser creditworthy communities to the better creditworthy communities. They wanted to own homes. But the phenomenon that restricted this was the era of segregation. And so through a variety of different strategies, some of which were not so gentle, people were either coerced or forced to move into those areas that were redlined. And coincident with this was a systemic disinvestment in those communities. Why is that important? I mentioned the emphasis here was on the COVID-19 deaths. These were the data generated out of Chicago. The dark brown zip codes is where the entirety of the burden of COVID-19 with the first wave existed. And the green areas are nodes demonstrating where the most significant rates of death occurred. And it's exactly coincident with the areas that originally were redlined. Now, if you follow this thought experiment, and I'm hesitant to say this is cause and effect, because we really want to think critically as scientists would. But if you follow this line of logic, it is possible that a well-intended decision made 90 years ago is in part responsible for the disproportionate burden we saw in deaths due to COVID-19 today. So now everyone gets to engage. Everyone gets to engage. I like participatory conversations. So we're going to do a series of thought experiments. You as well. Here's the first thought experiment. Consider the place you call home, whether that's your neighborhood here in Aurora or Denver, or the home with which you're familiar, where you resided as a young person. How'd you do with that first thought experiment? Here's the second thought experiment. Create a list quickly, of 5 people with whom you are close but unrelated. So not your children, Pam, but 5 people with whom you are close and unrelated. Here's your next thought experiment. Open a blank space, paper, electronic, even virtual. Write the names of 3 people you personally know who are incarcerated. Could you populate the list, or is it blank? This is not an indictment, but it's an effort to let you internalize what it means for people to live and try to thrive in very different circumstances. But then on the back end, to expect them to have the same sort of health attributes, it becomes a very difficult argument to validate. So what about bias in our everyday lives? I don't need to tell you the things that are happening in today's lay press, but I thought this was interesting. This already exists within the field of the news media, a bias scale. This is already extant, operated before any of these conversations. On the horizontal axis is political bias. On the vertical axis is overall social liability. The areas that are highlighted are serious liability issues and are extremism, up to more reliable for news. I don't need to say anything else, but you can see the display of the different news outlets from which we all gather at least some commentary, maybe even some nudging as to what we accept as truth. The point here, again, is not to indict any news organization. Sometimes I actually play on both sides of this fence because I like to know what's going on. But the point here is to say that as we begin to think as scientists would about this phenomenon of bias, it is ubiquitous. It's part of our housing circumstance. It's part of our own acculturation. It's part of the information we receive every day. Now, some of you, and I hope this is correct, have some disquiet right now, because this is your personal statement. I get that completely. But that may be because we have blind spots. So let's see if we can show this.
Are you seriously considering her as a candidate?
Don't trust her.
She's a woman.
She's a
This is
woman.
a man's
She's
job.
clearly not
Hey,
educated.
does she even speak English?
That's not me. I'm not like that. You call it an honest mistake. Science calls it a blind spot. Our unconscious mind is a mysterious and powerful thing. It makes 90% of our decisions without us even knowing it. Our brains are overloaded with 11 million pieces of information every second. Yet we can only process about 40 of them. So we're wired to make cognitive shortcuts, using past experiences to make assumptions. And you know what happens when we assume. Our unconscious mind can put us on autopilot, determining where we sit, who we eat lunch with, who we turn to for advice, and who we choose to offer a helping hand. Living our lives with blind spots can put us in a tunnel. Same point of view, same decisions, same outcomes. We can find ourselves trapped in the land of snap judgments and misconceptions. We've all been on both the giving and receiving end of blind spots. Think about it. Who's talented? Who's able? Who can I trust? Who belongs? We've all been there. Blind spots are part of the human condition. Our choices have consequences for us and the people we interact with. By accepting that blind spots exist, we can stop. Imagine what possibilities exist if we could do it all over again. Different perspectives, inclusive relationships, diverse networks, better outcomes, seeing people for who they really are. People like you with unlimited potential. We all have blind spots. Once you accept that you have them, you can choose to do something about it. It's time to check your blind spots and focus on what's possible.
The intention here was really to help us all begin to get away from the abstract when we're thinking about bias and appreciate that there's a way that we can all internalize this narrative. You've heard definitions, you see examples, and now in your own mindset, not in an open conversation with anybody else other than yourself, you can think about, is this pertinent? Is this relevant? And more importantly, we are physicians, we are doctors. We're given this amazing authority to make life-altering decisions about another human person. What kind of lens are we using? So what can you do if your own calculus says you need to think this through? This is an acronym from colleagues at Vanderbilt, and it's just pause. This is exactly what I teach my residents and students that round with me in the clinic when I know they're going to see someone behind the door that is not like self. Hand on the shoulder, stop, pause, exhale, so you can gather yourself momentarily before you go in the room and see something that may be different. So pay attention, acknowledge, understand, seek, and examine. So I've spent the first half getting your attention, provoking your thought process, elevating your norepinephrine maybe. But now let's think about solutions. How can we go into a different place? We'll start first with measurement, implementation, and a statement about digital health. This is an important document from NEJM Catalyst. Thank you so much, Dr. Kazan. But it really is distinguishing health equity and healthcare equity. This is a framework for measurement. I think this is right, and I'm so pleased that Pratiti brought this to my attention, because it helps us in our vernacular take another step forward, not only thinking about equity, but bifurcating the thought process into what's healthcare equity and then what belongs in this societal and structural environment. And how do we take a framework that goes from these two separate contributions to an improvement in overall health outcomes? And I'll go back one statement because I think this extracted statement really is a very important operational statement. When the inequities are measurable, proximate to healthcare outcomes, and actionable, then it belongs within our sweet spot. It's where we as healthcare leaders can operationalize plans because that's in our space. It's a little bit more difficult in the structural space and the societal space, but there are things that we can do in healthcare systems. It's implementation science way to do this. This is the great promise. I realize you have a strong implementation science group at University of Colorado. We got a stronger one at Northwestern. But we're all trying to figure out, can we leverage this unique resource and find a way to take what we know and more effectively do the things that are supposed to be done and do them in an equitable way. Once again, we see a roadmap. It's not really important to dissect this, but it is important to say that the key consideration here is that we need evidence to know that there is a right thing to do, there is a right way to do it, and it will effectuate better outcomes. And what about digital health? A number of my colleagues within the EP space, I met some of you last night here, but a number of my colleagues in the EP space are separately thinking about the technologies we use in arrhythmia management and treatment. And is that an area where we can narrow gaps or do gaps widen? This is the first time I'm going to mention something about McKinsey. Full disclosure, my younger daughter is a consultant for McKinsey, but these two projects are done by her colleagues, but without her direct involvement. But the argument made by the McKinsey colleagues just less than a year ago is that maybe this is the opportunity to advance health equity, yet others from the university, Brunel University in London, are reminding us once again that we have to be careful of the data inputs that go into using digital technologies to achieve health equity. If the data inputs are not equitable or at least inclusive in the beginning, we may end up in the same place. But this is the thing that's so uplifting. Larry Allen and I had this conversation just 9 minutes ago. Our respective institutions did a pivot within days from 100% in-person visits to 95% virtual visits. It can be done. And at that point in time, we all realized something unique. We were taking care of patients where they were comfortable in their home environment. And for many patients, that was a huge asset. And in Chicago, not having to fight traffic to get downtown, that was a gift. So can we do something with that going forward? What about addressing unmet needs? Can we use electronic health records now and better phenotype people, better understand risk profiles, better identify threats before threats actually occur? Our group at Northwestern is trying to identify people likely to get heart failure before they get it, so we can start with earlier intervention of evidence-based therapies. And clearly, anything that helps us move beyond the awkwardness of racial identifiers is a good thing. And then what about the historical context? Imagine how many patients still don't trust us and don't trust medicine, particularly post-pandemic. If we can use digital technologies to reestablish trust by putting things on a level playing ground, maybe that's a reasonable solution. What other solutions might we do? We can't do anything until we do what we've done for every disease process: hypertension, acute coronary syndromes, aortic stenosis, heart failure. We need the evidence so we don't start spending dollars needlessly. What about tactical steps? I'm going to tell you some things we're doing here in Chicago that I think are very helpful. We've developed a dashboard in our electronic health platform of the social determinants of health. We've been through 200,000 patients, and we were struck that 44% had at least one evident need in the domain of the social determinants of health. And we take care of a fairly healthy, well-insured population. 44% had a need, and 15% had an immediate critical need. But what was so gratifying about this was that there were already extant community services in the public health sector that could address those needs. We didn't have to make a single extra penny of an expenditure. We just had to be smart in our triage to the right public health entity. And so we're expanding this to an even larger space. What about the pipeline? You know, this has been my own project. I'm 12 years invested in this. High schools in Chicago recognize me when I show up. We identify ninth grade students have an interest in science. I've not lost a single kid. They've all graduated from high school. All but two have gone to college with scholarships, and my first kid is going to medical school. Now, Peter's here. If I say West Lawndale, you know what I'm talking about. If I talk about the South Side, Bronzeville, you know what I'm talking about. These are kids that were not going to medical school. These were kids that were going in coffins. And the kids we're touching are going to college and seeking professions in healthcare. And then this, we've extended our network now And we're building facilities for the first time truly in the neighborhoods where we serve. This is our Bronzeville project. This is our signature project. I've got 4 years invested in this. It will be boots on ground in 2025. But when we do this, 200,000 square feet to provide services to the community, and look what we've done so far. We've employed people from the community. We've employed diverse businesses. We've employed vendors to help us get started. 1,000 construction jobs in that community. That's real money that we're putting back into the community. We're building trust literally from the ground up to say we want to be a part of the community. And by providing, and this is not a cartoon. This is what it's going to look like. We hope that the families in Bronzeville will see that we're very serious about their health by doing this. So now we have probably the most difficult part of the discussion because this is so topical. Is there space in all of this now for professional diversity and inclusion? I've talked about social, I've talked about health, but what about at the professional level? I go back to 2020. H. Holden Thorpe is the editor-in-chief for the Science Enterprise. He received a lot of blowback on what I'm about to share with you, but nevertheless, he has stood firm in the statement that he articulated. And then science and scientists finally need to listen to and make space for people of color to lead laboratories that publish great science and produce influential scientists. And in the same statement was this remarkable companion statement from an underrepresented in science professional, a woman, who said, how much creativity are we leaving on the floor? So when you think about this, the argument becomes, yes, we need to think about access to care and providing environments and meeting patients where they are and all of the social models, but what about the professional models? Is this a reality? So this is really today's most tense question. Is diversity the solution or is diversity the problem? Today, some would say diversity is not the solution, while others would say diversity is not about unearned privilege, which is the point of contention, but it's about excellence. Are there lessons learned from corporate America? Let me show you this one model from Forbes. If you look at how teams make decisions and then evaluate decisions post hoc, was it an effective decision? Did it achieve the goal that was expected? So in the traditional model, with all men in the room, over half the time it is a good decision with a post hoc analysis, almost 60% of the time. But what happens when women are in the room, when there's gender diversity? That number goes to 73%. What happens when there's the lens of the early career individual and then the lens of the seasoned experienced individual? The quality of that decision-making goes up to 80%. And then what happens when it's age, gender, geography, race, and ethnicity? It gets up to 87% using the same algorithm. The argument being that potentially there is an opportunity for enterprises to function better with diversity, capital D, in the room where decisions are made. Our effort at doing this is executing on an NIH first proposal. I'm co-PI for a $16 million NIH grant. We call it Nurture, with the intention to do a cluster hire of 15 underrepresented in science persons to join our research labs. These are not clinicians, to join our research labs. This is an effort between us and the McCormick School of Engineering. We've already made our first 2 hires in our first funded initiative. But the idea is to challenge this notion and say we can prove, or at least we can argue, that by diversifying our scientific enterprise, we can do better science. So we'll see how that all evolves over time. But here's the area of the most tension. In January of 2023, this very provocative statement appeared in the New York Times. What if diversity training is doing more harm than good? Sometime before then, this is my second mention of McKinsey. This was near the height or just after the peak of the pandemic. Diversity wins, how inclusion matters. This is so diametrically opposed, so diametrically opposed. So let's deconstruct this and look at the juxtaposition. On the con side, creates more division, diversity is disruptive, diversity efforts are expensive, diversity efforts are not evidence-based, and diversity efforts don't value merit or achievement. This is the de facto argument put forward by so many voices now working against diversity initiatives. Well, what's on the pro side? This is from McKinsey. Gender diversity, 25% more likely to experience above average profitability, a metric which increased with increasing gender diversity. This is a survey of clients of McKinsey Corporation. 48% performance difference between companies with the most versus least gender diversity. What about ethnicity and culture? Companies in the top quartile of ethnic and cultural diversity outperform those in the fourth quartile by 36%. And here's an important takeaway. There was a variance in diversity versus inclusion. We always conflate those terms. It was 31% negative viewpoints about diversity. That's honest. I'm pleased to see that. 61% negative viewpoints about inclusion, particularly with the leadership lens. Here's the point of argument. Why is this in a grand rounds discussion? Science is no different at this point. These are operational activities. These are leadership dynamics. And we can begin to see what happens in some enterprises when things change and what the measurable output is. And we wonder where we are in science and health. Now, when I pulled this down in February, I thought, okay, this is an aberration. This is not who we are. But here it is. And it's kind of intimidating, actually. Was Dr. Blount that intimidating? Oh, no answer. Okay. But if we take this another step forward, there is, as best I can tell, a neutral website that now is tracking anti-DEI legislation across the country. This is as of April 2023. The darker colors, be that blue or black, are where bills are already introduced or approved targeting anti-DEI efforts. The red states are those that are on watch moving forward. I know for a fact Mississippi has moved forward. And the green states are those where no bills exist. Looks surprisingly, or maybe unsurprisingly, political. But this is where the world exists today. A number of us have had kind of whispered discussions about the SCOTUS decision. It will be released probably sometime this month. It's important for us not to think about what they will say, but what we already know, because we know more than we think we do. Affirmative action as an entity began in the 60s with LBJ and JFK, and it was really intended just to globally target non-discrimination. And it basically got exported, if you will, into education. The first real challenge of that was in 1978. We know about the Bakke case. It did allow the use of race as one of several attributes in the decision about, and again, medical school, we have to keep this in mind. In 2003, University of Michigan was ruled as having an algorithm that was too preferential, but still the incorporation of race was allowed to stand, and this was reaffirmed again in 2014. But there's this concept here of strict scrutiny. This I will read because I think it gives us a better platform to understand what's likely to occur. The legal tests that the Supreme Court uses in cases that involve equal protection of race is called strict scrutiny. To meet the burden, the schools must show that their policies serve a compelling government interest and use a narrowly tailored means to further that interest. In the Bakke decision, the court ruled that addressing historical racial injustice was not a compelling government interest, given its impact on individuals not responsible for that harm. However, in that case and all relevant rulings that have followed, the court has cited the creation of diverse student body as a compelling interest. In the cases presently before the court, the justices will again decide if diversity is a compelling enough interest to allow the schools to use race as a factor in admission. We know that Justice Alito has said he doesn't believe we can address what narrowly defined means. We know that Clarence Thomas doesn't understand, has verbalized this, so I'm not making a pejorative statement what diversity means. We know that the Chief Justice, Justice Roberts, has said, isn't it sufficient that an essay or a narrative that describes life experiences would qualify? We know that Supreme Court Justice Kagan says she believes that this is still a right and proper entity. We've got several justices that haven't spoke. So that's 4. We can figure out where they're voting. You can never figure out where the Chief Justice is voting. Maybe that's a good thing. But that gives you the context. And again, I bring this up because the part that I've extracted from what's in legal literature uniquely affects medical schools. What happens if the composition of our medical school classes changes? What happens if there are fewer women? What happens if there are fewer people with mobility challenges? What happens if there are fewer people with Asian Pacific Island heritage? What happens if there are fewer Spanish-speaking people? Everything that we're talking about regarding health equity changes or potentially changes. So that's why we're paying attention to this. I want to close with this last thing. No matter what the Supreme Court does, we have to go on. I plan to wake up July 1st, hopefully still have a job, and doing business and all the different things that I do. And whatever they say, I will start that day providing the best care, doing the best science, writing the best papers, and providing the best education. Leadership is important. What do I mean by that? If I were giving you a heart failure lecture, I'd talk about the 4 pillars of heart failure care. Pam Peterson knows exactly what those are. Our guidelines make it very clear. But I want to give you a different 4 pillars, and this is a takeaway for leaders. These are the 4 pillars of medical ethics. And this is out of a group in the UK that really thinks about ethical dilemmas in healthcare. The 4 pillars: the pillar of beneficence, the pillar of non-maleficence, the pillar of autonomy, and the pillar of justice. Beneficence, do the right thing. How core is that to being a physician? Non-maleficent, do no harm. That's an oath we all take. What about justice? Can we use some sense of the fair and equitable distribution of resources? And then what about autonomy? Are we bringing the patient into the conversation for some self-determination, some self-direction? So this is where I'll close. You know, I have the privilege of having been born in the Deep South and now living in Texas and then living in Illinois. Big cities, I've had the privilege of education. I'm in that 1%, that 5% we were talking about yesterday. But I also have another privilege. My mother was born in 1915. I was born when she was 42. So I have 100 years or greater of experiential understanding about life in this country. So I know full well what the Jim Crow laws were. I know full well what the impact of segregation was. I was living and breathing, maybe awake, during the Civil Rights Movement. I saw Black Panthers. I saw controversy. I saw angst, but I also saw legislation that protected non-discrimination. In 2020, we all saw the necessity to have these conversations about equity, but what happens next? I think it's a very uncertain future. So this is the summary. I do think this is a road that we as healthcare systems and leaders must traverse. If anything, medicine is that one profession that allows us to take the higher road and say, this is the right thing to do. Regardless of how we feel when we get home at the dinner table, this is the right thing to do. Health inequities are likely sourced from biases, explicit and explicit. We've had a bit of a primer on blind spots. Solutions are difficult. They're multifaceted, they're strategic and tactical, they're systemic, and some will be local. But I think diversity is still part of the solution. And I haven't said this before, but I'll say it right now. What's so important about diversity is not the percent of anything in the room. I frankly don't care. What I care about is the diversity of ideas. Do we have enough different ideas in the thought calculus as we make decisions about how we go forward? I think that's correct. There are evident threats we should know in days to weeks where that is. And for those of us that are charged with leadership, and I would argue that all of us, because of our place in society and in medicine, have some leadership ethos, we need to be aware of these 4 pillars of ethics. Thank you very much for this opportunity. I really appreciate it. Happy to answer any questions. And I hope that those of you that were connected with Dr. Blount will appreciate what we try to do today. So thank you.
I know it's close to 1 o'clock, but Dr. Carter, we do have time for questions.
Thank you so much, Dr. Yancy. I think this was a very courageous approach to this topic, and I appreciate it. It's quite motivating and inspiring. What I'd like to ask you is, how do you fold in metrics of accountability in this path to justice?
So I'll restate the question. How do you fold in metrics of accountability? Meaning, if we make a decision to do something here, how do we evolve some space where we can judge whether or not we've been successful? That's the reason why we need more evidence, because we have to understand what defines success. We have to realize that not everything we're doing or everything we're targeting is countable. This is a quote from Albert Einstein. Not everything that we can count matters, and not everything that counts is countable. And so we need to be really thoughtful about how we put together not short-sighted quarter by quarter metrics, but longitudinal change. Because what we're trying to measure, and why this is so hard, we're trying to measure culture change. And culture change does not really fit well with the customary way of counting. So to answer your question, accountability for efforts like this sits in the space of leaders. A leader with a lens that says, I believe this is part of my calling, our calling. I believe this aligns with our mission. I believe this is part of our core values. That's where the greatest accountability resides. But it's not countable. We need to keep that in mind. Yes, thank you.
Speaking of things that are not countable, first of all, thank you so much. That was a wonderful talk and very thought-provoking, as I think you intended. One thing that brings to mind as you're talking about things like diversity versus inclusion is the work of Brene Brown, and how she emphasizes that just counting, we have 50% women, we have 30% people of color, is not enough. And it really is that culture of inclusivity, of people who look different from those who are in power, which is the status quo for most institutions, still having a safe space to share their opinions, especially when they go against the way that we have always done things. And I'm just kind of wondering what your thoughts are on that nuance and how you bring it to your own leadership, and how, we could all learn from that.
It's interesting you raise this point. I was just accused of having courage. I'm old enough where courage doesn't matter much to me anymore. You, on the other hand, have courage to speak up in front of your peers and articulate as you did. There are many who say that the real problem with diversity and inclusion initiatives is that it allows leaders to park all of that dialogue into the diversity and inclusion space and not have to personally be invested and expect others to execute on this. And so it really is important that it's not just the counting exercise. I'll say it again, I really don't care how many people look like whatever model you wish in a room. I care more about how many people have voice. And that's why the advocacy and the engagement continues to be so very important. And I think the Forbes model is not a mistake. I mean, I've gone through the business literature. I could have shared with you 5 more that really validate the importance of having diversity of thought. And so one of the most important things I've learned in my several different pedagogical experiences in leadership is that ultimately these issues that are the big, hairy issues are couched in leaders in leadership. And so either leaders have to change or leaders have to change, meaning the people that are making decisions need to have a more expansive lens, or the people making the decisions need to reflect a different population. And so that's where we are. But you're the one that's courageous, so thank you for speaking out. Any other thoughts, questions, comments? Yeah.
Time for one more. I know folks have to get going, so if you do, please feel free. That's okay.
I will just reiterate what everyone said in terms of the presentation, not only provocative, but necessary. So thank you for that. The question that I have, you had a slide and you were referencing a very sort of remarkable approach that you all have in Chicago at your institution, which is the services, the resources, when you were able to have the dashboard that identified a significant amount or proportion of your patients that needed services, and you were all able to provide those services through referral and resources, et cetera, et cetera. Could you talk a little bit about the good and the bad, or the difficulty, if you will, as well as the positive of organizing that and what that really looked like, right? In an everyday
No, I understand the
carrying
question
that out.
very well. Let me just articulate it briefly. How do we actually effectuate this provision of social services to those with identified need in a place as large and complex as Chicago? Dr. Waddy. She is the public health officer for Cook County. And so by engaging with Dr. Waddy, we were able to say, sure, we've got this service. Sure, we've got this service. Sure, it's in this community. So it really was like this eureka moment where we had no idea it would be that easy to connect people to services. And the services were looking for patrons to partake of their services. But the threat is that now that we're in a different space vis-a-vis public health and the pandemic, Dr. Waddy's resources are a threat of being defunded. So that's the real threat. As long as that remains intact, and I don't know what the corollary is in Denver, but as long as that remains intact, we've been able to cultivate that relationship and keep it going. So much so that the business community in Chicago invited me recently to sit with them and explain how we work with the public health system to address these issues. Because one of the things that was so remarkable amongst their leadership is that they realized that every business, not just the healthcare enterprise, every business has a role in equity. And that was very gratifying. Now, maybe Chicago is, and it is an aberration of sorts, but there you go.
Dr. Yancy, I hope if you have a few extra minutes to stay up front, that would be great. If folks have other questions, I am sorry that we have to cut this off, but I do want to end by saying just thank you so sincerely. You have not been here before. We don't usually have people sitting on the windowsills. I'd like to tell you that we do, but they're here for you and they're here for your message and for what it can do for this campus. So thank you very much.